Picture this. You've just navigated major vascular surgery. The relief is immense. But what comes next, often unseen, is just as vital for your journey back to health.
Absolutely.
So today, we're doing a deep dive into that crucial world of post-operative management for vascular patients.
Precisely. And we're drawing from a comprehensive textbook chapter on vascular surgery and endovascular therapy.
Right.
We want to really unpack this pivotal recovery phase for you.
Right, like getting the insider knowledge on what happens after the operating room doors close.
Exactly. Think of it that way.
Okay, let's unpack this. Because recovery isn't just about, resting up.
Not at all.
It's a really intricate and coordinated effort, isn't it?
Mm-hmm.
It starts the moment surgery ends and stretches well beyond your hospital stay.
It really does. And understanding the priorities, maybe some potential hurdles at this stage, it can be incredibly helpful for you.
Mm-hmm.
Our aim here is to be your informed guide, sort of extracting the essential information without getting lost in overly complex medical terms.
Yeah, keep it clear.
We want to provide a clearer picture of what's involved and, importantly, why it all matters.
Okay, so right after surgery, where does the focus go? What
Yeah.
takes top priority?
Well, it actually starts even before you leave the operating room.
Oh, really?
Yeah. Based on your preoperative cardiac risk assessment, they use something called the Revised Cardiac Risk Index, or RCRI.
RCRI, got it.
The team already has an idea of the intensity of care you'll likely need afterwards.
Okay.
If more than 3 risk factors pop up on that index, the textbook really emphasizes considering more intensive monitoring.
More intensive, like what?
Potentially including invasive hemodynamic monitoring. Getting a closer look at heart function and fluid status.
Right. And you mentioned 3 risk factors. What kinds of things does that index look at?
Well, the specific factors are detailed elsewhere, but generally it's looking at your pre-existing health.
Mm.
Things like heart problems, kidney function, diabetes, maybe previous strokes, that kind of thing. The key insight here is that identifying that higher cardiac risk beforehand, it directly influences how closely you'll be watched after surgery.
Makes sense. Plan ahead.
Exactly. And in very high-risk situations, the surgical team might even think about simplifying the procedure itself.
Ah,
Or, if the risks just seem too high compared to the benefits, maybe even considering non-surgical options instead.
that's a crucial decision point. So it's about tailoring the plan right from the start.
Definitely.
Now, you mentioned deciding on the level of care needed,
Mhm.
like ICU versus a step-down unit. What determines that?
Yeah, that's a big one. There are several factors that are pretty strong indicators for needing that higher level of intensive care, ICU.
Like what?
The textbook lists things like advanced age, having COPD, that's chronic obstructive pulmonary disease,
Right.
significant blood loss during surgery, say more than 500 cc, which is about half a liter.
Wow, okay.
If the operation took a long time, maybe over 5 hours.
5 hours is quite a while.
Yeah. It often signals a complex case. And also, if the surgery involved the area near the kidneys, what's called juxtarenal disease.
Mm-hmm.
These all suggest, a higher chance of needing that very close, continuous monitoring you get in an ICU. Basically, a tougher surgery puts more strain on the body.
Got it. More strain, more monitoring needed.
Precisely. But there are other validated predictors, too.
Okay.
Things like having severe coronary artery disease. Specifically, if your heart's pumping strength, the ejection fraction, is below 40%.
That's quite low.
It is. Also, a history of congestive heart failure, or if you experience significant chest pain with minimal activity, it's called NYHA class 3 or phi angina.
Right.
Other factors include being dependent on dialysis, needing a ventilator right after surgery, needing management of a spinal drain if one was placed,
Okay.
ongoing blood transfusions, or if there was any unexpected instability, like big drops in blood pressure during the operation itself.
So it's a really comprehensive look at your health and what happened during the surgery.
Exactly. Very thorough.
Yeah. What about these step-down units you mentioned? They sound like a middle ground.
They are. Step-down units, they're often equipped for cardiac monitoring, and they have better nurse-to-patient ratios than a regular floor. The example given is like 2 patients per nurse.
Good one. Okay.
They're being used more and more in vascular surgery. And what's interesting, studies have shown that for some patients, like those recovering from certain aortic surgeries, the outcomes in these step-down units can be just as good as in the ICU.
Really? Same outcome?
Yeah.
Yeah.
And this can also lead to significant cost savings. An ICU bed is, well, considerably more expensive.
Right.
So it's about finding that right balance, the appropriate level of care that's also cost-effective.
It's good to know there are options tailored to different needs. Okay,
Yeah.
so once someone is settled in the right unit, ICU or step down, What's the immediate focus? Monitoring, I assume?
Absolutely. Continuous and careful physiological monitoring is crucial. And the textbook makes a really key point here. Just because your blood pressure and heart rate are within a normal range
Mm-hmm.
doesn't automatically mean that your organs are getting enough blood flow and oxygen. Adequate perfusion.
Okay. So normal isn't always optimal.
Exactly. So the medical team will be looking at a much wider range of indicators to make sure everything's functioning okay.
Okay, tell me more about those indicators. It's not just the basics then.
No, it's a much more detailed picture. Beyond blood pressure and heart rate, they'll be monitoring things like central venous pressure, CVP.
CVP.
That gives an idea of the pressure in the big veins returning blood to the heart. They might also look at pulmonary capillary wedge pressure that helps assess pressure on the left side of the heart.
Right.
Cardiac output, how much blood the heart is pumping each minute, that's key.
Mm-hmm.
Urine output is a big one, reflects kidney function. They'll also monitor blood lactate levels.
Lactate, that goes up when tissues aren't getting enough oxygen.
Right, exactly. They might also look at tissue carbon dioxide levels, base deficit, which tells you about acid-base balance and the oxygen and CO2 levels in your mixed venous blood.
Mixed venous. So
Yeah.
blood returning to the heart after circulating.
Yes, it gives a good overall picture of how well oxygen is being delivered and used by the whole body.
Wow, that sounds like a huge amount of data to track.
It is, but fortunately, technology is helping. The textbook mentions newer, less invasive devices.
Like what?
Like the ClearSight system. It's a non-invasive way to continuously track several key hemodynamic parameters: cardiac output, stroke volume, vascular resistance, mean arterial pressure, all without needing an arterial line.
No arterial line. How does it work?
It uses a special finger cuff and sophisticated calculations based on the pulse waveform. Pretty neat.
That is interesting. Less invasive is usually better if possible.
Definitely.
Okay, let's dive into some of those specific tools you mentioned. Central venous catheters and CVP. What's their main role, and what are the key things to know?
Right. Central venous catheters, or CVCs, they're primarily used for a few critical jobs: giving fluids, especially large amounts quickly, administering potent drugs that affect blood pressure, vasoactive drugs, and assessing the volume status, how much fluid is in the circulation. But, and this is important, the chapter highlights some limitations when using CVP specifically to guide fluid replacement.
Limitations. I kind of thought CVP was a direct measure of hydration.
It's a marker, but it's not the whole story, CVCs are usually placed in large veins, internal jugular in the neck, subclavian in the chest, or femoral in the groin. Now, for CVP readings from the neck or test lines to be accurate, the tip has to be in the right place, in the distal superior vena cava, the big vein just before the heart.
Placement is key.
Absolutely. And while femoral lines are great for getting fluids in fast, they aren't ideal for measuring CVP because pressure inside the abdomen can throw off the reading.
Like squeezing your belly affects the pressure reading higher up.
Kind of, yeah. Intra-abdominal pressure interferes. So what does CVP reliably tell us?
Good question.
It mainly reflects the pressure in the right atrium of the heart. That gives an estimate of preload, basically how much the heart muscle is stretched before it pumps.
Okay, preload.
But this relationship isn't always straightforward, especially if you have lung disease like COPD or certain heart valve problems. Those can affect the reading.
Right.
The textbook also stresses getting the setup right. Zeroing the transducer, the pressure measuring device, at the correct level, usually the mid-axillary line, roughly level with the heart.
Mid-axillary line, okay.
Normal CVP is typically around 6 to 12 millimary Hg. And if you're on a ventilator, the reading should ideally be taken at the very end of you breathing out and expiration, when chest pressure is most stable.
Little details matter.
They really do. High levels of PEEP on the ventilator can also artificially raise the CVP reading, and a sudden change in CVP. That could signal a problem, like a collapsed lung or fluid around the heart.
Lots to consider just for CVP. What about peripheral arterial lines? The chapter called them the gold standard for blood pressure. Why?
Yeah, gold standard. They earn that because they give you continuous beat-by-beat blood pressure readings, real-time info.
Okay, not just periodic checks.
Exactly. Plus, they give direct access for arterial blood sampling. Super important for checking blood gases like oxygen and CO2 levels.
Right, but downsides. Risks.
Like any invasive line, yes. Potential risks include bleeding, hematoma, that's like a bruise under the skin infection at the site, blood clot formation, or thrombosis. And though it's rare, reduced blood flow to the limb, ischemia.
Where do they usually put them?
Most common site is the radial artery in the wrist,
Okay.
followed by the femoral artery in the groin. The textbook advises against using arteries in the foot or the other artery in the forearm, the ulnar, in vascular patients, just because circulation might already be compromised there.
Got it. Radial versus femoral, any big differences in risks?
Yeah, there are some trade-offs. Radial lines have a slightly higher risk of temporarily blocking the artery, though it usually resolves. Femoral lines have a higher risk of bleeding and something called a pseudoaneurysm, like a contained leak. But, interestingly, they have a lower risk of forming a clot within the vessel itself.
And getting accurate readings. Same deal with zeroing.
Absolutely. Zeroing, again, ideally at the level of the heart, is crucial. The chapter also mentions potential errors from dampening.
Dampening. What's that?
It's when the pressure waveform gets kind of smoothed out or distorted. Can happen due to the tubing length, air bubbles, kinks, stuff like that.
Okay. And that affects the reading.
It can mess with the systolic top number and diastolic bottom number readings, making them less reliable individually. But the interesting thing, it often doesn't significantly affect the mean arterial pressure, the MAP.
MAP again. So that's why MAP is often emphasized. It's more robust against these measurement issues.
Exactly. Because dampening can skew systolic and diastolic in opposite ways, the average pressure, the MAP, often remains a more accurate reflection of overall perfusion pressure to the organ.
Okay, that makes sense. Use the average.
Most modern monitors calculate it automatically anyway. Clinically, it's often the number people target.
Right. So we've covered CVP, arterial lines. What about pulmonary artery catheters, PACs? I feel like I used to hear about those all the time.
You did. PACs or Swan-Ganz catheters, they can provide a lot of detailed info. Intracardiac pressures, how well the ventricles are pumping, mixed venous oxygen saturation.
So really deep physiological data.
Very deep. They were used extensively, especially in complex cardiac patients or major surgeries, but their use has declined quite a bit.
Why the decline?
Well, mainly because several large studies didn't actually show they improved patient survival rates.
Oh.
And some data even hinted they might be associated with increased complications or potentially mortality in some groups.
So the benefit wasn't clearly outweighing the risks.
That seems to be the conclusion for routine use. Plus, they are quite invasive.
So when are kegs still considered? Are there specific situations?
Yes, the textbook suggests they might still have a role in very complex surgeries with high cardiopulmonary risk, or in the ICU to help figure out and manage tricky situations like severe heart failure, cardiogenic shock, or when the right and left sides of the heart aren't working well together. Also, maybe in severe valve problems or pulmonary hypertension.
So specific diagnostic or management puzzles.
Exactly. Guiding complex fluid management or vasoactive drug use in really sick patients.
And the risks you mentioned, what are they?
Well, there are risks with placing any central line. Then threading the catheter through the heart chambers can cause arrhythmias, usually temporary, but still. There's a specific risk of causing complete heart block if you already have a left bundle branch block on your ECG.
Oh, wow.
Other potential issues. The catheter can get knotted. It could rupture a pulmonary artery, very serious, though rare bits could break off. It could injure the heart. And prolonged use increases infection and clot risk.
Okay, quite a list.
While death directly from a PAC is rare, the overall risk-benefit calculation has shifted towards more selective use.
Makes sense. A powerful tool, but use it wisely. Let's switch gears to echocardiography. That's ultrasound of the heart, right?
Yeah.
Non-invasive.
Exactly. Echo is a huge tool in cardiovascular care. Very valuable and non-invasive way to monitor and diagnose heart issues around surgery time.
How does it help? What can you see?
It uses sound waves to create moving pictures. You can assess how well the heart muscle is squeezing contractility, see the size of the chambers, look for wall motion problems suggesting ischemia, check how the valves are working, look at blood flow patterns. Really informative.
Yeah, there are different types. The chapter mentions transesophageal echo, TE.
Right. T involves putting a small probe down the esophagus behind the heart for clearer pictures.
Okay.
Now, large studies haven't really backed up using T routinely during all non-cardiac surgeries, but the textbook highlights its huge value when a patient suddenly becomes hemodynamically unstable. You know, blood pressure crashes, circulation fails.
For acute problems.
Yes. TEE can rapidly help figure out why. Is it severe dehydration? A massive heart attack? A pulmonary embolism? Fluid around the heart? Tamponade? TE can often give you answers quickly.
Like a diagnostic shortcut in a crisis.
Pretty much. It's also shown to be more sensitive than a standard ECG for picking up signs of ischemia, reduced blood flow, though the exact meaning of some subtle wall motion changes is still debated a bit.
More sensitive than ECG. Interesting. Can it measure function too?
Yes. Using Doppler, TE can calculate cardiac output, and those measurements correlate well with PAC data. It's also better than wedge pressure at detecting changes in preload, how full the heart is, and it can even estimate pressures inside the heart chambers.
So quite versatile.
Huh.
What about the other type, transthoracic echo, TTE? That's the one on the chest wall.
Exactly, the standard echo probe on the chest. Traditionally, may be used less intraoperatively by anesthesia compared to T.
Okay.
But the textbook points out that experienced intensivists, the ICU docs, are increasingly using focused TTE exams right at the bedside in the postoperative period.
Focused exams, like quick checks.
Yeah, targeted assessments. They can quickly look for things like a weakened left ventricle, signs of hypovolemia or dehydration, problems with the right ventricle, major valve issues.
And that helps guide treatment right away.
Exactly.
Yeah.
Allows for timely interventions, maybe give fluids, maybe start a heart-supporting medication, and helps decide if a full cardiology consult is needed.
So both TE and TTE offer really valuable, often non-invasive insights.
Absolutely. Key tools.
Now, something maybe less intuitive. The chapter discusses intra-abdominal pressure, IAP. Why monitor pressure in the belly after vascular surgery?
Yeah, it might seem unrelated, but elevated IAP defined as consistently over 20 mmHg can cause big problems. It's called abdominal compartment syndrome in severe cases.
How does it cause problems?
That increased pressure can squeeze organs and blood vessels. It can reduce blood flow to the kidneys, causing kidney injury or failure. It can compress the big veins, returning blood to the heart, reducing cardiac output. And it can push up on the diaphragm, making breathing harder and increasing pressure needed from a ventilator.
Wow, a real domino effect.
It can be multi-organ dysfunction. So monitoring it, especially after major abdominal vascular surgery or if there's a lot of swelling, is important.
How is it measured? Is it complicated?
Actually, it's usually done pretty simply via a bladder catheter. Instill a small amount of saline into the bladder, then measure the pressure reflected back.
Through the Foley cath. Oh.
Yeah, done with the patient lying flat at the end of expiration and zeroing the transducer at the level of the pubic bone.
Another pressure point to watch. Finally, in this monitoring section, the chapter mentions some newer devices. Can you give us a couple examples?
Sure. Innovation is ongoing. The chapter highlights two. First, that ClearSight system we touched on earlier.
Right, the non-invasive cuff.
Yeah, uses plethysmography in the finger to continuously estimate MAP, stroke volume, cardiac output. Really useful for patients without an arterial line who still need close hemodynamic watching.
Good alternative.
What's the other one? The second is the FlowMet R system. This also goes on a finger, kind of like a pulse oximeter.
Oh.
It uses laser imaging to give continuous real-time info about blood flow in the extremity. It provides a number and a waveform.
So it's measuring actual flow in the finger.
Seems like it, yeah. Assessing peripheral perfusion could be helpful during surgery to check flow to a limb after a bypass, or in the ICU to monitor limb circulation, especially if someone's on ECMO or has concerns about graft function.
Interesting tech. Okay, that's a really solid overview of all the ways they keep tabs on hemodynamics and pressure. Let's move into how the cardiovascular system is managed after surgery, starting with hypertension, high blood pressure. The chapter says it's quite common.
Very common. Several things can trigger it after vascular surgery.
Such as?
Well, the body's stress response itself, low oxygen, high CO2, fluid overload, being cold, bladder distension, agitation, pain, all can drive pressure up.
Makes sense. Stress, IBP.
And importantly, a common culprit is rebound hypertension.
Rebound.
Yeah, if you were taking blood pressure meds before surgery and they weren't restarted soon enough afterwards, your pressure can shoot back up.
Missed doses.
Exactly. And untreated high blood pressure right after surgery. Not good. Increases the risk of bleeding from the surgical site.
Okay.
Also, a history of high diastolic pressure before surgery is a predictor. And high pressure makes the heart work harder, increasing its oxygen demand, which can lead to myocardial ischemia, especially if you have underlying heart disease.
So step one is figure out the cause and treat that if possible.
Absolutely. Address the hypoxia, pain, agitation, whatever it is.
And what are the general blood pressure targets?
Usually the goal is to keep your systolic blood pressure, the top number, within about 20 mmHg of your pre-surgery baseline.
Okay, close to their normal.
Yeah. And significant deviations in the mean arterial pressure, MAP, say more than 20% above baseline, should probably be treated too.
What kind of meds are used?
Ideally, you want meds that work fast, don't last too long so you can adjust the dose easily, and can be given safely intravenously right after surgery.
Makes sense for titration.
Common choices include beta blockers, calcium channel blockers, maybe ACE inhibitors, and often intravenous vasodilators that can be carefully dripped in.
The chapter also flags hypertensive crisis. That sounds serious.
It is defined as systolic over 180 or diastolic over 110, but there's a key distinction,
Which is?
whether it's a hypertensive emergency or urgency.
Okay, what's the difference?
An emergency means that super high pressure is also causing acute, ongoing damage to major organs, brain, heart, kidneys. Think acute stroke, heart attack, aortic dissection, flash pulmonary edema.
Wow. Okay, immediate threat.
Exactly. These need immediate treatment to lower the pressure carefully but relatively quickly to limit that organ damage.
How quickly? You don't want to drop it too fast.
Right, you don't want to cause shock. The initial goal is often to reduce MAP by maybe 10-15%, max 20% in the first hour, aiming for a target like 160-100 over the next few hours, as long as the patient tolerates it.
Okay. And hypertensive urgency.
That's the severely high BP without those signs of acute progressive organ damage. Here you have more time. The pressure can be lowered more gradually, maybe over hours to days, often using oral medications.
Less immediate danger.
Right. Interestingly, people in urgency often lose a lot of salt and water, so sometimes they actually need fluids along with BP meds. But the key is treatment is tailored, response is watched closely, and then you transition to a good oral regimen once stable.
Got it. Careful management based on the situation. Now let's flip to the opposite. Hypotension, low blood pressure. The chapter says defining it can be tricky.
Yeah, there's no single magic number. What's low for one person might be fine for another.
Depends on their baseline.
Exactly. But the main point is, if hypotension is severe or lasts a while after surgery, it's linked to bad outcomes. Increased risk of organ problems, heart injury, stroke, kidney failure, even clots forming in surgical graft.
So even if it seems borderline, the team takes it seriously?
Definitely.
What usually causes low blood pressure post-op?
Few common culprits. Lingering effects of anesthesia are one. Hypovolemia, just being low on fluids, is a big one. Cardiac dysfunction, the heart not pumping well. And sometimes a state of vasodilation where blood vessels are too relaxed, maybe due to sepsis or inflammation.
Okay. And management. Treat the cause again.
Always the first step. If low volume is suspected, give IV fluids. But judiciously.
Judiciously.
Yeah, you need to consider the Frank-Starling curve. Giving too much fluid if the heart is already struggling can actually make things worse.
Right. Don't overload a weak pump.
A large variation in the pulse pressure between breaths on a ventilator can sometimes suggest responsiveness to fluids. And crucially, you have to quickly rule out surgical bleeding as the cause.
Absolutely. Top priority. What if fluids aren't enough?
If BP stays low despite adequate fluids, then you need vasoactive drugs, pressors. Short term, something like phenylephrine or dopamine might be used peripherally until a central line is in. Then, more potent agents like norepinephrine or vasopressin, which are better at increasing systemic vascular resistance, are usually given centrally.
What if the problem is the heart pump itself cardiogenic dysfunction?
Right. In that case, just squeezing the pipes with pressors might not be the answer, could even worsen things by increasing the heart's workload.
So what do you use?
You'd lean towards inotropes drugs like epinephrine or dobutamine that make the heart muscle contract more forcefully, though they can sometimes trigger arrhythmias, so you watch closely. Ensuring adequate fluid volume, euvolemia, and a normal heart rhythm are also vital in this situation.
What if things are still looking bad? Persistent low pressure? Maybe signs of heart strain?
If hypotension persists and you suspect ischemia, like a heart attack is contributing, then it's time for urgent cardiology consultation. May need cardiac catheterization to see what's going on in the coronary arteries.
And potentially more support.
Yes, potentially mechanical circulatory support things like an intra-aortic balloon pump, IABP, Impella device, or even ECMO might be needed if medications aren't enough. Cardiogenic shock after surgery carries a very high mortality risk.
And in that specific scenario, you'd avoid certain meds.
Yes, in cardiogenic shock post-MI, you generally avoid drugs that weaken the heart muscle, like beta blockers or calcium channel blockers.
Wow, a real balancing act. Okay, moving from pressure to arrhythmias, irregular heartbeats. The chapter says folks with pre-existing heart issues are at highest risk.
That's right. And post-op triggers are common. Low oxygen, high CO2, electrolyte imbalances, acid-base issues, ischemia.
So lots of potential triggers.
Definitely. Treatment goals are basically keep the patient stable hemodynamically, control the heart rate, and ideally get back to a normal rhythm.
The chapter splits them into fast, tachy, and slow bradyarrhythmias. Let's tackle the fast ones first. What are the common tachyarrhythmias?
Lots of possibilities. Sinus tachycardia, just fast, normal rhythm. Atrial fibrillation, AFib is a big one. Also, ectopic atrial tachycardia, junctional tachycardia, multifocal atrial tachycardia, AV nodal reentry tachycardia, AVNRT. And then the ventricular ones, ventricular tachycardia, VT, and ventricular fibrillation, VF.
Okay, quite a list. How are they managed generally?
The supraventricular ones originating above the ventricles are often managed by controlling the rate, usually with meds that slow conduction through the AV node, the electrical gateway between the top and bottom chambers.
Like beta blockers or calcium channel blockade?
Exactly, or sometimes digoxin or imiodarone. The ventricular rhythms often need specific antiarrhythmic drugs.
How common are the supraventricular ones after surgery?
Fairly common, maybe 4–13% incidence range mentioned. Short bursts might not need treatment, but you still want to look for the cause, electrolytes, pain, etc.
Right.
For sustained episodes in a stable patient, again, find the cause, then control the rate. Beta blockers, calcium channel blockers cautiously if heart function is poor, or IV imiodarone. For AVRT specifically, in stable patients without WPW syndrome, adenosine can sometimes terminate it.
And if the patient is unstable with any of these?
Unstable means immediate electrical cardioversion. Shock them back into rhythm.
Okay. What about the ventricular tachyarrhythmias? The chapter sounds more concerned about those.
They often are more ominous, especially in patients with known coronary artery disease. How they're managed depends on duration, appearance on ECG, and stability. Having underlying structural heart disease matters too. Critically important is treating predisposing factors, fix low potassium, low magnesium, hypoxia, ischemia to prevent deterioration.
Right. Preventative steps.
If VT causes instability, that's an emergency. Full ACLS protocol, including defibrillation if needed.
And stable VT.
Stable monomorphic VT looks consistent on ECG. It can often be treated initially with IV antiarrhythmics like amiodarone, followed by a prompt cardiac workup.
Okay. What about polymorphic VT and VFib?
Those are really bad news, often linked to acute MI and can rapidly cause circulatory collapse, need urgent defibrillation and IV antiarrhythmics. There's a specific type of polymorphic VT called torsades de pointe, with a characteristic twisting look on the ECG.
Torsades. What's the treatment?
First line is IV magnesium. If that doesn't work, sometimes drugs like isoproterenol or overdrive pacing to speed the heart up slightly can help. Unstable torsades with a pulse needs synchronized cardioversion. Pulseless torsades gets defibrillated immediately, just like VFib.
Magnesium first for torsades, got it. Let's focus on atrial fibrillation, AFib. The chapter says it's the most common post-op arrhythmia after non-cardiac surgery.
By far. Affects around 10% of patients undergoing major non-cardiothoracic surgery. Often pops up in the first few days post-op.
And it's not benign.
No, it's associated with increased mortality, longer ICU stays, longer hospital stays overall.
What are the risk factors? Who's more likely to get it?
Older age, male sex, having pre-existing valve disease, previous history of AFib.
Makes sense. And triggers post-op.
Lots of things can precipitate it. Low potassium or magnesium, fluid overload, stopping beta blockers or ACE inhibitors abruptly, underlying lung disease like COPD, obesity, sleep apnea, infections, especially pneumonia.
And why is AFib problematic hemodynamically?
The rapid, irregular atrial rate messes up ventricular filling. You lose that coordinated atrial kick, the final squeeze from the atria that tops off the ventricles.
Ah, the kick.
That loss can decrease stroke volume by 20–35%, which can be critical if you already have issues like diastolic dysfunction, where the ventricle doesn't relax well.
Okay, so treatment goals for AFib.
3 main things. Control the ventricular rate, try to restore normal sinus rhythm, and prevent thromboembolism, blood clots.
Clots are a big risk with AFib.
Huge risk, especially stroke. So if someone's unstable, low BP, pulmonary edema, chest pain, the priority is urgent synchronized cardioversion. Shock them back.
And if they're stable.
Then the first step is usually rate control. Meds like beta blockers, calcium channel blockers, maybe digoxin or amiodarone. Amiodarone can sometimes chemically convert them back to sinus rhythm too.
What about cardioversion for stable patients? Need to worry about clots first.
Yes. If the AFib has been going on for more than 48 hours, or you don't know how long, The standard is to rule out a clot in the left atrium first, usually with a T.
Look before you shock.
Basically, if you can't rule out a clot and the patient is stable, you typically anticoagulate them with heparin first for a period before attempting cardioversion. But if they're unstable, you cardiovert first, then manage anticoagulation.
Okay, complex decision tree there. Lastly, for arrhythmias, let's touch on the slow ones, bradyarrhythmias.
Right, the slow heart rates. Things like sinus bradycardia, sinus pauses, various types of heart block, usually less of a diagnostic challenge.
What causes them post-op?
Often increased vagal tone, the body's slowing down nerve, or sometimes ischemia affecting the heart's natural pacemaker.
And treatment. Often just watch.
If they're transient and the patient is hemodynamically stable, often no treatment is needed. Just observe.
But if it's sustained and causing problems, low BP, dizziness.
Then you treat. First step is often atropine, an antimuscarinic drug that blocks the vagal effect and speeds up the heart.
Atropine.
If atropine doesn't work, you might need an infusion of dopamine or epinephrine to stimulate the heart rate, or temporary pacing, either transcutaneous pads on the chest or a temporary transvenous wire.
Pacing as a backup. Got it. That covers arrhythmias really well. Let's move to myocardial infarction, MI heart attack. Leading cause of cardiac complications and death in these patients, the chapter says. How is it detected post-op? Pain isn't always reliable, right?
Right. Post-op pain, analgesia, sedation can all mask typical angina symptoms, so you rely on other clues too.
Like the ECG?
ECG changes, particularly in the ST segment, can indicate ischemia or infarction. But the chapter notes, especially after major vascular surgery, some ST changes can occur without a significant blockage. Still, any ST change is associated with increased risk.
Okay, so ECG is suggestive, but not definitive alone sometimes. What else?
Cardiac enzymes, or biomarkers, CKMB and especially cardiac troponin I.
Troponin. That's very sensitive for heart muscle damage.
Very sensitive and specific. The key point is, even if you don't have symptoms, elevated troponin levels after major vascular surgery are significant. They predict higher risk of post-op MI and mortality down the line.
So routine troponin checks might be done even without chest pain.
Often, yes. Especially in higher risk patients or after very major procedures. It helps risk stratify.
Okay, let's talk types of MI. ST segment elevation MI, STEMI. That's the big one usually.
Typically, yes. Usually caused by complete blockage of a coronary artery from plaque rupture and clot formation. It's a true emergency.
Diagnosis, ECG, and enzymes.
Yes. Classic ST elevation on ECG and specific lead patterns. Enzymes like CKMB and troponin rise within hours.
Treatment priorities for STEMI post-op.
Rapid resuscitation oxygen, maybe meds to reduce workload, antiplatelet agents like aspirin, heparin if bleeding risk isn't prohibitive. And the absolute key is urgent reperfusion. Get that artery open.
Reperfusion? How?
Either fibrinolysis clot-busting drugs or preferably primary PCI, percutaneous coronary intervention, angioplasty and stent.
Is fibrinolysis safe right after surgery?
That's tricky. The bleeding risk might be too high depending on the surgery. It's an individualized decision. PCI is generally preferred if available quickly.
And bypass surgery, CAB.
Usually reserved if PCI fibrinolysis fails or if there are complications like coronary dissection. And beta blockers should generally be started right away, unless there are contraindications like shock, severe bradycardia, or heart failure.
Okay. What about the other type? Non-ST segment elevation MI and STEMI.
And STEMI means you have the elevated biomarkers, the troponin, indicating heart muscle damage, but you don't have that classic ST elevation on the ECG.
So damage is happening, but maybe not a complete sudden blockage.
Exactly. Often it's due to ischemia from a supply-demand mismatch post-op. Maybe a narrowed artery limits flow when the heart's demand increases due to stress, fever, tachycardia.
Ah, okay. Less often a plaque rupture.
Can be, but often it's the supply-demand issue. Presentation might be shortness of breath, worsening heart failure, not necessarily classic chest pain. ECG might show two-wave inversion or ST depression, less specific changes. The key is the elevated troponin.
And prognosis.
Mortality risk is proportional to how high the troponin level goes. Higher troponin, worse outlook.
Treatment for NSTEMI. Less focus on immediate reperfusion.
Generally, yes. Treatment is primarily medical initially. Optimize oxygen delivery, reduce the heart's demand, control pain, heart rate, BP, prevent recurrence. The ABCs are often mentioned. Aspirin, ACE inhibitor, beta blocker, statin. Heparin might be beneficial, balancing bleeding risk. For ongoing chest pain, sublingual nitroglycerin can be tried if BP allows. Morphine if nitro isn't enough.
So stabilize medically first, then often risk stratify for later intervention if needed.
Exactly, a different approach than STEMI.
That's a really clear distinction. Okay, shifting from the heart to the lungs pulmonary management. Post-op respiratory support is often needed after big surgeries.
Definitely. Especially long thoracic or thoracoabdominal procedures, cases with big fluid shifts, or when significant pain control like epidurals or high-dose opioids might affect breathing.
And problems can be with oxygenation or ventilation.
Right. Oxygenation failure means hypoxemia, low blood oxygen. Ventilation failure means hypercapnia, retaining too much CO2.
When ventilation is the issue, mechanical ventilation, the breathing machine, comes in.
Correct. Usually positive pressure ventilation. It assists or takes over breathing.
How does it help?
Well, you control oxygenation mainly by adjusting the FiO2, the percentage of oxygen delivered, and the airway pressures like PEEP. You control ventilation CO2 removal mainly by adjusting the tidal volume, how big each breath is, and the respiratory rate.
Sounds straightforward, but are there downsides?
Yes. Positive pressure can disrupt the normal matching of ventilation and blood flow in the lungs, VQ mismatch. It can affect blood circulation back to the heart, and there's a risk of ventilator-induced lung injury, VALE.
Valley, injury from the ventilator itself.
Yeah. Barotrauma is injury from too much pressure. Volutrauma is injury from overstretching the lung sacs. Atelectrauma is damage from repeated opening and closing of unstable air sacs, especially in conditions like ARDS.
Wow, okay. How are those prevented?
Using lung protective strategies, lower tidal volumes, appropriate levels of PEEP to keep air sacs open, and avoiding excessive pressures.
The chapter mentions different modes of ventilation. Sounds complex.
It can seem that way. Traditionally, you had controlled modes, machine does all the work, and supported modes, patient triggers, machine helps.
Okay.
And delivery could be volume control, set volume pressure varies, or pressure control, set pressure volume varies. Modern classifications are more detailed, looking at control variable, targeting scheme, breath sequence, lots of acronyms like BC, CMV, PCIMV.
Right, the acronyms. What's the practical difference right after surgery?
If the patient is making minimal effort, a controlled mode is often best initially to rest the breathing muscles and ensure adequate ventilation.
Pressure or volume control? Does it matter?
Depends. Pressure control PCV sets a pressure limit, which might be better for protecting the lungs in ARDS, reducing peak pressures. Volume control, VCV, guarantees a set volume delivery, which ensures CO2 removal, but pressures can rise if lung mechanics worsen, though there are usually pressure alarms.
So tailoring the mode to the situation and preventing that VIL is always key. You mentioned PEEP helps.
Yes, positive and expiratory pressure. Applying a small amount of pressure at the end of exhalation helps keep the tiny air sacs, the alveoli, from collapsing completely.
Like splinting them open.
Exactly. Prevents atelectrauma and improves oxygenation, usually set between 5-15 centimeter H2O, depending on the patient. There's also biotrauma, the inflammation triggered by mechanical stress that can affect other organs. So minimizing VLO is crucial.
Once someone's on a vent, the goal is to get them off ACA, right? Weaning.
Absolutely. Weaning is the process. 2 phases. Readiness testing and extubation.
Readiness testing.
Assessing if the patient is stable enough to handle reduced support often involves interrupting sedation, the up and breathe trial, and seeing how they do on minimal settings or spontaneous breathing trial.
Spontaneous breathing trial, like breathing on their own through the tube.
Yes, maybe with just a little pressure support or CPAP, or even just connected to oxygen via a T-piece for 30 minutes to 2 hours. Studies suggest these trials can lead to earlier extubation if successful.
How do you know if a trial is successful?
Basically, they don't show signs of distress. No rapid breathing, no drop in oxygen saturation, stable heart rate and blood pressure, no agitation or obvious struggling to breathe.
And if the trial is successful, then extubation.
If they pass the trial and the original reason for intubation is resolved and they can protect their own airway, good consciousness level, cough reflex, manageable secretions, then yes, extubation is considered.
Are there contraindications? Reasons not to extubate?
Yes. Altered mental status where they can't protect their airway, copious secretions they can't clear, no cough reflex. Also need to consider if intubation was difficult, initially need backup ready.
Because reintubation is risky.
Failure increases mortality and need for longer ventilation. Reintubation happens in maybe 10-15% of cases, which is within the typical ICU range, but you want to avoid it if possible.
What about tracheostomy? When does that come into play?
Tracheostomy, placing a tube directly into the windpipe through the neck, is considered if prolonged ventilation, say 10, 14 days, is anticipated.
Advantages.
Can improve comfort, reduce work of breathing, make suctioning secretions easier, allow for oral hygiene, potentially allow speech with certain valves.
Disadvantages.
Risks of the procedure itself, stoma complications, and rare but serious things like tracheoinnominate fistula, erosion into a major artery, or tracheoesophageal fistula.
Is earlier tracheostomy better?
Some evidence suggests early track within the first week for expected long-term ventilation might facilitate weaning and shorten hospital stay, but outcomes vary depending on the patient group. Can be done surgically or percutaneously at the bedside.
Okay, that covers breathing support thoroughly. Let's talk about another major post-op concern. Bleeding. The chapter says unexpected high fluid needs should ring alarm bells.
Absolutely. If you're pouring fluids in way beyond what's expected, you must suspect and evaluate for bleeding urgently.
What are the typical signs of hypovolemia from bleeding?
Tachycardia, fast heart rate, hypotension, low BP, low CVP, decreased urine output, cool, clammy skin from peripheral vasoconstriction, the classic signs of shock.
And it could be surgical bleeding or a clotting problem.
Exactly. In the early post-op phase, an unstable patient needing escalating pressors. Assume surgical bleeding until proven otherwise. The chapter mentions the bloody, vicious cycle. Bleeding uses up clotting factors, leading to more bleeding.
So act fast.
Very fast. Point-of-care testing, like ISTAT in the PAC-UEC, for quick clotting assessment. Alert the OR, get blood products ready. If unstable, may need to go back to surgery immediately. If stable, imaging might help find the source.
And if it's not surgical site bleeding, but a coagulopathy?
Then you need immediate lab tests, APTT, PTINR, platelets, fibrinogen to figure out what part of the clotting cascade is off and guide specific treatment.
Like giving.
Protamine to reverse heparin, specific factors if deficient. Vitamin K for warfarin reversal, fresh frozen plasma, FFP, for multiple factor deficiencies. Platelets if count is low. Cryoprecipitate for fibrinogen. Maybe tranexamic acid to prevent clot breakdown. Tailored therapy based on the labs.
Okay, let's shift to fluid and electrolyte management more broadly. Needs are individualized, right?
Yes, no one size fits all. Many stable patients can use weight-based maintenance fluids like the 4-2-1 rule. Key is titrating to affect urine output as a good guide if kidneys are working. Avoid fluid overload if possible.
What type of fluids? Saline, lactated ringers.
If large volumes of crystalloid are needed for resuscitation, balanced salt solutions like lactated ringers, LR, or plasmolate are generally preferred over normal saline.
Why?
High volumes of normal saline can cause hyperchloremic metabolic acidosis, which isn't ideal. Balanced solutions are closer to the body's natural electrolyte composition.
What about colloids like albumin?
No proven survival benefit over crystalloids in most critically ill patients, so crystalloids are usually first line. Albumin might be used in specific situations, but not routinely for volume.
And electrolytes. Potassium, magnesium.
Need daily checks, especially potassium K, magnesium Mg, and phosphate. Replete based on levels. Be extra careful with potassium replacement if there's kidney insufficiency. Some surgeries might have standing orders for repletion due to expected losses. Sodium imbalances also need careful management based on volume status.
Okay. The chapter also briefly flags renal failure, kidney problems. Biggest predictor.
Pre-existing renal insufficiency. If your kidneys weren't great before surgery, they're at higher risk afterwards.
Any specific kidney protective drugs proven effective?
The chapter notes that low-dose dopamine hasn't shown benefit, and data on phenoldiprem is controversial. Management relies on careful fluid resuscitation, avoiding kidney-toxic drugs, and sometimes using loop diuretics if needed.
Got it. Let's move into some important general considerations. First up, gastrointestinal ischemia, poor blood flow to the gut. Sounds nasty, especially after aortic surgery.
It's a serious complication. Can range from mild mucosal injury to full-thickness bowel necrosis. Incidence is higher after emergency ruptured aneurysm repair compared to elective surgery.
How does it present? What are the signs?
New abdominal pain, maybe bloody diarrhea or lower GI bleeding. Lab signs might include high white count, acidosis. Imaging could show free air in the bowel wall, pneumatosis, or even air in the portal vein system.
How is it managed? Depends on severity.
Yes. If a patient is stable and endoscopy shows only mucosal ischemia, grade 1, they might be managed conservatively: bowel rest, hydration, broad-spectrum antibiotics.
But if they worsen or are unstable?
Immediate surgical exploration is usually needed. Unstable patients or those with more advanced ischemia, grade 3, found on initial assessment also need urgent surgery to improve chances of survival.
What does surgery involve?
Depends on findings. Sometimes reestablishing blood flow, like IMA reimplantation, is possible if the bowel is viable. If there's frank gangrene, resection of the dead bowel is necessary, often resulting in a colostomy, like a Hartmann's procedure.
Okay. Next general topic. Nutrition. Important for healing, obviously. How are needs assessed post-op?
Standard short-term markers can be misleading due to inflammation. Goals are usually set based on estimated needs, typically 20-25 kilocalc day acutely, maybe up to 25-30 during recovery. Protein goals are around 1 g kilogram, potentially higher, up to 1.5 g kilograms in severe stress like trauma or burns.
How is nutrition delivered? Gut preferred.
Enteral nutrition feeding via the gut is strongly preferred over parenteral nutrition IV feeding whenever possible.
When should it start?
Ideally, within 24-48 hours of ICU admission, even trickle feeds initially, advancing is tolerated over the next couple of days. Can use a gastric tube or a post-pyloric tube into the small bowel if gastric emptying is slow.
And if enteral feeding just isn't feasible?
Parenteral nutrition, PN, might be considered, but usually only if nutritional support is expected to be needed for more than 7 days. Shorter durations of PN carry risks without clear benefit. Keep trying enteral access even if PN is started, and don't stop PN until enteral feeds meet at least 60% of needs.
Okay, gut first, IV as backup for longer needs. Pain management also crucial. Chapter mentions a multifaceted approach.
Yes, because post-op pain can have different sources.
Yeah.
Nociceptive, tissue damage, inflammatory, ischemic, lack of blood flow, neuropathic, nerve injury. Recognizing the main driver helps choose the best treatment.
And multimodal is better.
Definitely. Using different classes of drugs, opioids, NSAIDs, acetaminophen, nerve blocks, often works better and reduces reliance on opioids. Preemptive analgesia and regional anesthesia, like epidurals or nerve blocks, can significantly improve control and lower chronic pain risk.
Why is pain control so vital in vascular patients?
Uncontrolled pain triggers a major stress response: high heart rate, high BP, increased oxygen demand, which can be detrimental with underlying cardiovascular disease.
Benefits of regional neuraxial anesthesia.
Reduced opioid needs, often faster return of bowel function, possibly lower risk of blood clots and lung issues, facilitates earlier mobilization. Big benefits.
But requires careful timing with blood thinners.
Absolutely critical. Need to follow strict guidelines, like ASRA guidelines, about when to place or move catheters relative to anticoagulation doses to minimize the risk of epidural hematoma, bleeding around the spinal cord. Very important safety consideration.
Right. DVT prophylaxis preventing leg clots, standard procedure.
Yes, all vascular surgery patients need DVT prophylaxis post-op unless there's a major contraindication like active bleeding.
What's typically used?
Low molecular weight heparin, LMWH, is often preferred over unfractionated heparin due to lower risk of HIT, heparin-induced thrombocytopenia. Early ambulation and pneumatic compression devices are also key components.
When is anticoagulation started?
Timing can be a bit controversial, balancing clot risk versus bleeding risk, but many protocols start at fairly early post-op, often within hours if bleeding is controlled. Continue until fully ambulatory, maybe longer, up to 30 days, in very high-risk patients.
Okay. What about patients already on oral anticoagulants like warfarin before surgery? Do they need bridging?
Bridging with heparin or LMWH is typically reserved only for patients at very high thromboembolic risk.
Like who?
Main examples are mechanical mitral valves or older generation mechanical aortic valves, maybe recent stroke or VTE. For most others, just stopping the oral anticoagulant beforehand and restarting after surgery when safe is sufficient. It's a careful risk assessment by the surgeon.
Got it. Alcohol withdrawal, something to watch for.
Yes, can occur 24-48 hours post-op in patients with significant alcohol use, peaking around days 3 to 5.
Symptoms.
Range from mild agitation, nausea, tremors, to severe seizures, delirium tremens, or DTs.
How does it manage?
The CIWA-R scale helps assess severity and guide treatment, usually with benzodiazepines for significant symptoms. Crucial to rule out other causes of confusion like hypoxia. Give thiamine multivitamins prophylactically to prevent Wernicke-Korsakoff syndrome.
Okay. Last big topic. Sedation and delirium in the ICU. Delirium seems common and serious.
Very common, especially in older post-op patients. It affects up to half of some post-op groups. It's an acute state of confusion, inattention, altered consciousness. Significant because it's linked to longer stays, higher mortality, long-term cognitive issues.
How does this present? Just agitation.
Can be hyperactive, agitated, restless, but also hypoactive, quiet, withdrawn, lethargic, which is easily missed or mixed.
How is it diagnosed?
The Confusion Assessment Method, or CAM, often CAM ICU, is a validated bedside tool, sensitive and specific.
And if CAM is positive, what contributes?
Many factors: underlying cognitive impairment, age, psychoactive meds, especially sedatives, opioids, being on a ventilator, untreated pain, sleep deprivation, sensory impairment.
Treatment.
Focuses heavily on non-pharmacologic strategies first. The ABCDEF bundle is often cited: manage pain, awakening breathing trials, choice of sedation, delirium assessment management, early mobility, family engagement, reorientation, familiar objects, reducing noise, ensuring glass shearing aids are used. Pharmacologic treatment is secondary. Review all meds, use lowest effective doses of sedatives, analgesics. Antipsychotics like haloperidol are sometimes used cautiously for severe agitation, but evidence is mixed and arrests cardiac, extrapyramidal, need monitoring. Newer atypicals are also used off-label sometimes.
So prevention and non-drug methods are key.
Absolutely.
The chapter wraps up with a practical algorithm for fluid management, and the CAM tool itself really reinforces the hands-on nature.
Exactly. These provide structured ways to approach common, complex post-op challenges.
So pulling this all together,
Yeah.
it's undeniable that post-operative management after vascular surgery is incredibly complex, multi-system, and just critical for recovery.
That's the core message, isn't it? It's not just recovering, it's active dynamic management across physiology.
And those initial hours and days, that immediate post-op period, it's just paramount. Requires intense vigilance to spot and manage potential issues, from hemodynamics to organ function, before they escalate.
Precisely. That early phase truly sets the trajectory for the entire recovery journey. Get it right early, and the chances of a smoother path improve dramatically.
It really highlights the intricate balance needed, which leads to a final thought. Considering all this complexity, this careful balancing act the medical team performs, what are maybe the most significant ways you, as a patient, can actively participate in your own care during this time? Beyond just following instructions, how can patients feel more engaged or empowered in this critical phase? Makes you think, doesn't it?